In this lecture, we will start with the mastication process. We are done with the salivation. Okay, now we do the mastication, then followed by the deglutition. Okay, so we are done with the salivation process. We have seen the regulation of the salivation, and now we will go for the chewing or the mastication process. Okay, so the purpose of chewing or the mastication is to break the large food particles and mix the food with the saliva. Okay, so that's the major role. So this is like the wetting and the homogenizing actions, and it helps for swallowing and subsequent digestion. So the number of chews that is optimal is 20 to 25. It's okay, it's like just an optimal range. Okay, so edentulous means the people who don't have the teeth. Okay, edentulous patients are generally restricted to soft diet. Okay, and have considerable difficulty eating dry food. Okay, so like powdery food, like if you want to eat milk powder, so if a person doesn't have the teeth, it's very difficult to eat the dry food, like for example the milk powder. Okay, so these are the muscles of mastication, the muscles of the mastication, so which is like not so relevant for the physiology. This we will study in detail about these muscles in anatomy. Okay, so the temporalis, this is the external pterygoid, the internal pterygoid, the masseter. Okay, these are the important muscles. So what is like slightly relevant over here is to know the nerves that supply. Okay, so these are the mainly the fifth cranial nerve, especially the V3. Okay, the third branch of the trigeminal. Okay, the trigeminal supplies, except for the buccinator, which is supplied by the facial nerve. Okay, the buccinator is in the cheeks. Okay, the cheek muscles. Okay, so when the facial nerve paralysis happens, what will happen? You get drooling of saliva. Okay, you may not have the problem with the actual mastication, but you will get, because the cheek muscles are weak. Okay, the buccinator weak. What will happen? You will get the drooling of saliva if the facial nerve is weak. Okay, so there is the seventh nerve. So that is not mainly concerned with the mastication, but still an accessory. Okay, but the major nerve that supplies is the trigeminal. Also remember, these are all skeletal muscles, so this is not supplied by the sympathetic or parasympathetic. There is no involvement. It is directly the nerve that supplies to the skeletal muscle. Okay, the skeletal muscle it supplies, and the neurotransmitter always that is acetylcholine, and the receptor is the nicotinic receptor. Okay, the nicotinic. So because these are skeletal muscle. Okay, so moving on. So the chewing is actually not like a voluntary or involuntary. Instead, we consider chewing as a reflex action. Okay, so the brainstem area, the brainstem is the major one that is involved. Okay, the nucleuses like reticular formation. Okay, and stimulus from hypothalamus, amygdala, sensory areas of the taste and smell, etc., will lead to rhythmical chewing. Okay, you can see it's linked with amygdala. Amygdala is the emotional brain. Okay, emotional nucleus. Okay, so it is more related to emotions. Maybe you might have heard that like small kids, when they sleep, they might chew under the emotion. When they have like some emotions going on in their mind, what will happen? They do the chewing during the sleep. Okay, so we call that condition as a bruxism. Okay, so that is why, like, it's amygdala is involved, emotions are involved. Maybe like even as an adult, when we get angry, we may have like that sensation to chew or like bite very strongly. Okay, so and the normal chewing act as a reflex. Okay, so how does that reflex work? The presence of bolus of food in the mouth, okay, will first initiate the reflex inhibition of the muscles of mastication. So first it inhibits and cause dropping of the jaw. Okay, the drop initiates the stretch reflex. Okay, because of the muscle spindles on the skeletal muscle. Okay, the muscle spindles that is located inside the skeletal muscle. Okay, that will be like it blocks and drops, initiates the stretch reflex of the jaw muscles, leading to the rebound contraction. Okay, so this automatically raises the jaw, but it also compresses the bolus again against the inner linings of the mouth, which inhibits the jaw muscles once again, allowing the jaw to drop and rebound another time. So this is repeated again and again. Okay, so that's how it's like acting as a reflex. Reflex is something like, we don't put the mind while it is being undergoing. Similarly, like walking out, but consciously, if you ask, like, can we control the chewing? Yes, you can control. We can, like, consciously, effortfully, like, control that. But mainly, it happens by reflex. Okay, unknowingly. Okay. So that's simple. Like the deglutition part is the next one. Okay, the chewing part is like very simple as far as the physiology is concerned. It mainly involves a lot of muscles that is important for the anatomy. Okay, as far as the physiology is concerned, mastication is simple. Okay. Okay, so next is swallowing or the deglutition. Okay, the deglutition includes three phases. Okay, first is the voluntary phase or the oral phase, then is the pharyngeal phase, and the third one is the esophageal phase. So first is the voluntary, or otherwise sometimes called as the oral phase. Okay, so can we include the mastication in this process? No, we don't normally include that. After the mastication, we convert that food particle into a bolus. Okay, and then the bolus of the food is being pushed towards the pharynx. Okay, so that pushing of the bolus towards the pharynx is called as the oral phase. Okay, so what are the things that happens so this is completely voluntary. That means only skeletal muscles are involved. Okay, only the skeletal muscles are involved over here, purely skeletal muscle. Okay, next is the pharyngeal phase. Okay, pharyngeal phase also is skeletal muscle. Okay, but again there are like little bit of reflex activity and automaticity seen, which is not like fully controlled, even though it involves skeletal muscle. Esophageal phase is smooth muscles. Okay, is smooth muscles, mostly smooth muscles. Okay, whereas these two phases involves skeletal muscle. Okay, especially even the upper part of the esophagus, even the upper esophageal sphincter includes the skeletal muscle part. Okay, later on it becomes purely smooth muscle. Okay, so the pharyngeal phase. What are the things that happens in the pharyngeal phase? Okay, let's see over here. Okay, so as the food is moving, you can see, as the food is moving down, you can see the food is being pushed upwards, okay, towards the soft palate, and this part over here is called as the uvula, or the soft palate is getting pushed upward, okay, closing the nasopharynx so that the air does not flow down. Okay, so and also the food particle does not go up. Okay, it prevents the moving of the food particles into the nasal cavity. Okay, so initially it is the hard palate, then there is a soft palate. When you are like pushing the bolus of the food towards the pharynx so that it begins the pharyngeal phase. Okay, the first thing that happens is the pushing of the soft palate upward so that the food does not go into the nasal cavity. Okay, so that is the first thing. And then in the pharyngeal phase, what is the next event that is very important? You have to prevent the entry of the food into the trachea. Okay, so this is the trachea. Okay, so this is the trachea over here. You want to prevent the entry of the food particle into the trachea. So what covers the opening over here? The opening is called as the glottis. The glottis is covered by the epiglottis. So you can see as the food particles are moving down, what will happen to the epiglottis? It will also move down. You can see it will move down, and see over here it closes off the trachea. So the food is like guided towards the esophagus. Okay, the guided towards the esophagus. So it is also a voluntary phase because these muscles are voluntary muscles, but this does not happen like a voluntary action. It is like mostly like an involuntary action or a reflex action. Okay, so this is like a reflex action even though the skeletal muscles are getting involved. Okay, then after that, once it has passed down through the upper esophageal sphincter, so this is here you have your upper esophageal sphincter, then we call it as the pharyngeal phase is over, and then we start the esophageal phase. Okay, so the esophageal phase includes two peristalsis, the primary peristalsis and the secondary. Most of the food particle will go down just by the primary peristalsis. Okay, but if the food is like a little bit hard and it cannot move, especially in a person who is like in a supine posture, okay, lying down in the bed as a patient. Okay, so what will happen? They may not get the support of the gravity, so they may have to initiate the secondary peristalsis. So if the food is little bit dry or it is difficult to move down, then you need to initiate the secondary peristalsis. So the basic point is primary peristalsis. Only when the primary peristalsis reaches to the last part of the esophagus, the lower esophageal sphincter. Okay, at the end of the esophagus, you have what? The lower esophageal sphincter. Okay, the lower esophageal sphincter will open. Okay, so secondary peristalsis is not the one that controls, it is the primary peristalsis. When it reaches the lower esophageal sphincter will open and allow the food to move down. Okay, so that's what happens. So let's see what are the nerves that is involved in this. Okay, so that causes the peristaltic movements within your esophagus and the other nerves that controls. Okay, so the deglutition reflex is response that is triggered by the afferent, the sensory nerves. Okay, that is going through the trigeminal, the fifth one, the glossopharyngeal and the vagus nerve. Okay, so the trigeminal, glossopharyngeal and the vagus nerve, these are the afferents. Okay, and these are integrated in the nucleus of tractus solitarius. Remember, nucleus of tractus solitarius is the basic sensory window. Okay, sensory nucleus, all the sensory from the viscera, all visceral sensation. Okay, all viscera, all the sensation from the viscera is going to the nucleus of tractus solitarius. Okay, and also for this deglutition, it is even for the salivation and from the stomach, all the sensory for the respiratory system, for the cardiovascular system, the sensory information mainly have a relay to tractus solitarius. Okay, and then little bit part to the nucleus ambiguous. Okay, so they are integrated in these two parts. Okay, from there the efferent fiber, that means the motor fibers, these are the motor, and afferent means these are the sensory fibers. Okay, the efferent fibers pass to the pharyngeal musculature and the tongue via the trigeminal, facial and hypoglossal. Okay, so trigeminal is there for both sensory and for the motor. Okay, but for the motor you have the facial and the hypoglossal, for sensory you have the glossopharyngeal and the vagus nerves. Okay, so just keep in mind the name of these nerves. Okay, and also like maybe in your clinical skills you will study about the gag reflex. Okay, gag reflex. Okay, remember about the gag reflex when you study about that. Okay, so the 9th and the 10th cranial nerve is involved over there. Okay, 9th and the 10th cranial nerve involved. Okay, so that will initiate the reverse peristalsis over here in the gag reflex. When you stimulate the pharyngeal region, okay, the things can get reversed. Okay, so that's about the deglutition process, the process. Okay, as we have already discussed. Okay, initiated by the voluntary action, when it's voluntary, collecting the oral contents on the tongue and propelling them backwards to the into the pharynx. Okay, this starts a wave of involuntary contraction in the pharyngeal muscles that pushes the material into the esophagus. Okay, now at the same time what will happen, there will be inhibition of respiration and the glottic closure, that the glottis is closed by the epiglottis. Is part of the reflex response. If it does not happen, if this closure does not happen, then you get what? Aspiration. Okay, aspiration, which can cause like complications like what? Aspiration pneumonia. Okay, aspiration pneumonia. Okay, especially seen in alcoholics. Okay, especially seen in alcoholics because their muscles will be weak, and when they try to eat, what will happen? They may end up in aspiration pneumonia. So what happens? The food particles can go into the trachea. Okay, if the closure is delayed, or if a person try to talk at that time, because the glottis is guarded by the on either side of the glottis you have the vocal cords. So if you try to talk while in the pharyngeal phase, definitely what will happen? The food will get aspirated into the lungs. Okay. So remember that. So a peristaltic ring of contraction of the esophageal muscle forms behind the material, which is then swept down the esophagus at the speed of 4 centimeters per second. Okay, that's just the speed of like the normal speed for the primary peristalsis. So when humans are in upright positions, liquids and semi-solid foods generally fall by gravity because they go very fast. Okay, to the lower esophagus ahead of the peristaltic fluid. Okay, so that means the gravity can help, especially for liquid and semi-solid foods. Okay, so here comes very important like application aspect, that is in your lower esophageal sphincter. okay, the lower esophageal sphincter. So what happens over here? There are three components, the components of that. Okay, so the intrinsic sphincter, that is the smooth muscle. Remember that they are smooth muscles. Okay, and then you have the extrinsic sphincter, which is a part of the diaphragm, which is a skeletal muscle. Okay, it's a skeletal muscle. And there are sling fibers of the stomach wall that prevent the regurgitation when intragastric pressure arises. Okay, it goes up, so the sling fibers will come and block the lower esophageal sphincter. These are called as the sling fibers over here. Okay, so when the muscle is the stomach is contracting, this will move inwards and then blocks the entry of the food particles or the stomach content back to the esophagus. That's the role of it. Okay, so the diaphragm, which includes the costal part and the crural part forms the sphincter over here. This is skeletal muscle. Okay, this part is skeletal. Okay, the diaphragm is a skeletal muscle. Okay, whereas the inner, this is the lower esophageal sphincter, which is the internal part. This part is the smooth muscle. Okay, the smooth muscle. Okay, so what are the disease conditions that we can get over here? One of the things that you will study in your histology is about the Barrett's esophagus. Okay, so when the acid comes over here, it will cause the changes to the epithelium over here. Okay, so the normal epithelium will start to change, they will start to proliferate and causes the changes. That is what we refer to as the Barrett esophagus. Okay, so when a patient is showing the Barrett esophagus, what you have to understand that the acids are reflecting back. What is that condition called as? That is called as the GERD. Okay, that condition is referred to as the GERD. Okay, or the gastroesophageal reflux disease. Okay, GERD. Okay, sometimes also referred to as, like in some books you can see it as GORD. Okay, just the spelling of the esophagus. Okay, the esophagus, there some places it will start with O, so it may be GORD. So don't confuse, they are the same thing, GERD or GORD. Okay, so another condition is achalasia. So achalasia is opposite to that of GERD. That means the lower esophageal sphincter is very tight. It is not allowing the food to pass down. Okay, so when the acids are reflecting back, it creates the burning sensation. The patient will complain as a burning sensation. Whereas when the food is not going down, it is too tight. How the patient will complain? They feel like heaviness. They feel like a big stone or something is kept on their chest. Okay, they will feel the heaviness. Okay, so that is the major complaint for the achalasia. Okay, for the achalasia, so what they complain is heaviness. Okay, so in which the food accumulates in the esophagus and the organ becomes massively dilated. Okay, and it's due to increasing lower esophageal tone. Okay, lower esophageal sphincter tone. Okay, and incomplete relaxation upon swallowing. Okay, so let's see what causes it. Okay, so the contraction is caused by which neurotransmitter? The acetylcholine neurotransmitter. Okay, acetylcholine neurotransmitter. Okay, so these are the smooth muscles, and the acetylcholine influences it to relax. Okay, so through the muscarinic receptor. Okay, so the muscarinic receptor, it helps to relax but to contract. Okay, the contraction is caused by the acetylcholine. Okay, so now how to stop its contractility over here? The sphincter contractility is caused by what? An inhibitory neuron. Okay, caused by inhibitory neuron. Okay, the inhibitory neuron. So the inhibitory neuron normally here releases the neurotransmitter nitric oxide. Okay, so nitric oxide. Okay, so what happens in the achalasia is that the inhibitory neurons are not working. Okay, the inhibitory neuron that releases nitric oxide is not working, so there will be too much of contraction caused by the acetylcholine. Okay, so one of the treatment approach is to reduce the release of this acetylcholine. How to reduce? One of the treatment approach that is using is to reduce the release of acetylcholine. Maybe we have studied before. What is that substance that can reduce the release of? It is the Botox. Right? Sometimes we may inject the Botox so that you don't release the acetylcholine. It will stop the release of the acetylcholine when you inject the Botox. So it is the botulinum toxin. Okay, the botulinum toxin that we have discussed in our first chapter. Okay, in the muscle. So Botox, if you inject, the acetylcholine release will be inhibited, so there won't be contraction. So it will cause a relaxation, and that is one of the treatment approach. But that is not the reason for the disease. The reason for the disease is the inhibitory neuron not working. So whenever the food comes over there, you need to the lower esophageal sphincter should get inhibitory input through the inhibitory neuron by releasing the nitric oxide as the neurotransmitter. But if it does not get released, it will show increased contractility and increased tone. Okay, so that is what happens in the achalasia, increased resting lower esophageal sphincter tone. Okay, so what is the opposite condition? The opposite condition is lower incompetence. Okay, too much of opening of the lower esophageal sphincter. Okay, and it which permits the reflux of the acid contents into the esophagus. Okay, so that is what is called as the GERD. Okay, this condition causes heartburn. That is one of the important symptoms, and esophagitis can lead to ulceration and stricture of the esophagus due to scarring. That is what we have seen before. That is the Barrett esophagus, when the acid goes into the esophagus, the histological change that can be observed. Okay, so these are the two important disease conditions that you must be remembering with regards to lower esophageal sphincter and for the exam point of view. Okay, so now let us see one important question just as an example over here. Okay, so over here they are trying to describe a patient like 25-year-old, a 25-year-old male. Okay, seen for dysphagia. Dysphagia means difficulty to swallow. Okay, so he states that whenever he eats anything solid, he develops painful sticking sensation in the center of his chest. Okay, so that is like a heaviness. Okay, so painful, okay, heaviness or the sticking sensation in the center of his chest. Okay, so he can ingest liquids with some discomfort, but more liquid in the food bolus, but the more liquid in the food bolus, the easier it is to get down. So as far as the liquid is concerned, it is becoming easier for that to go down, but when it is solid, it is becoming difficult. Okay, so he has not noticed any choking or gagging. So because the choking and gagging is the upper part. Okay, it's a problem especially within the upper esophageal sphincter or in the pharyngeal part, etc. Okay, so he is from Brazil and immigrated to the United States when he was 18 years old. Okay, he has no non-medical history and up to date in all vaccination and takes no medications. So he drinks alcohols on the weekends, does not smoke and does not use illicit drugs. His vitals are normal as is his physical exam. Laboratory shows an abnormalities in the BMP, LFTs, liver function test and CBCs, the complete blood count. Okay, so what the physician has done, a barium swallow is done and is shown in this image over here. So this image you can see barium is like a radioactive substance over here. So when you scan, you can see very clearly the substance when you ingest. So you can see it has become wide. Okay, and you can see this is like a beak of a bird. Okay, so bird beak appearance. Okay, so this is referred to as the beak appearance. Okay, the beak appearance over here, so that here the contraction and the food is unable to go down. So you can see over here the food is getting accumulated in the esophagus and it is causing the swelling of the esophagus. Okay, so that clearly tells you this is achalasia. So which of the following is the most likely cause of his dysphagia? The answer is achalasia. Okay, so achalasia is the cause over here, and this is very classic. Okay, whenever you see a beak appearance over here, the bird beak appearance over in the lower esophageal part, then you have to understand it is achalasia. Okay, now importantly, once you understand this part, okay, so the important, now let's go into the physiological question of it. Okay, so until now what you have seen is mostly that what we are going to study in your pathology. Okay, all these phenomena and all these properties and why the importance of traveling to Brazil and trypanosomia, disease condition can also precipitate achalasia, etc. You will learn more in pathology. Okay, but as far as the physiology part is concerned, once you know that it is achalasia, then what are the things that you have to know? Okay, that is very important over here. Okay, so additional workup. Okay, so what is this? Okay, will reveal if you do further study on this patient, that means which of the following will be revealed. Okay, so will this patient show increased acetylcholine activity in the lower esophageal sphincter? Yes. Okay. Yes, this is possible. Okay. So increase in ganglion cell concentration in the myenteric plexus? No, right, not possible. A decrease in ganglion cell concentration in the submucosal plexus? No, that is not an option for the achalasia. That is not the reason for the achalasia. Okay. Now, hyperperistalsis of the distal 2/3 of the esophagus. Hyperperistalsis means it will become easy for the food to move. So that is not the cause. Okay. Now, this one, decreased nitric oxide activity in the lower esophageal sphincter. This is also true. Okay. So what is happening? Because of the decreased nitric oxide activity, that is from the inhibitory neuron. Okay. From the inhibitory neuron. Okay. It releases nitric oxide. Okay. So the nitric oxide. So when the inhibitory neuron is releasing nitric oxide, what will happen? The acetylcholine will not be released and the sphincter will relax. Okay. So because there is a decrease in the nitric oxide activity, what is happening in the lower esophageal sphincter? There is an increased acetylcholine activity and the lower esophageal tone is increased. So which one will you pick out of these two? Okay, these two looks almost the same, but this is not the primary cause. Okay, so this is not the answer. So the primary cause for achalasia is what? This one, the decreased nitric oxide activity in the lower esophageal sphincter. But as when you think like a treatment approach, what we do is what? To stop the release of acetylcholine. Okay, we stop the release of acetylcholine by giving the Botox. Okay, we give the Botox and stop the release of acetylcholine. That is like a treatment approach, but that is not the cause for the condition. The cause for the physiological cause for the condition is not the increased acetylcholine, but what happens? Increased nitric oxide activity. Okay, so when there is an increased nitric oxide activity, inhibitory neurons, okay, nitric oxide inhibition, so what will happen? There will be less too much of acetylcholine being released and causing achalasia, too much tightening of the neurons. Okay, so that's for this topic. Okay, so we will continue in the next video. Thank you.